Honorable national and international faculties, respected teachers, and my dear fellow colleagues, Assalamu alaikum. I am Dr. A.K.M. Ziaul Haq, Vascular and Endovascular Surgeon from NACBD. I welcome you again to the SINA Vascular Live webinar program. This is our 31st session. Today's program scientific partner is Optimate Germany and Plasma Biotech. Today our topic is carbon dioxide as a contrast in peripheral vascular intervention. Today, our keynote speaker is Dr. Raghuram Shekhar. He is now working as consultant, vascular and endovascular surgery department, Kokulaben Dhirubhai Ambani Hospital, Mumbai, India. Today, we are also honored by the presence of Dr. M Abidur Rahman from USA and Professor Dr. Naresh Chandra Mondal, head of the department, National Institute of Cardiovascular Disease, and Dr. J. M MOKBUL HOSSAIN from Ibn Sina Hospital. Now, I would like to request Dr. J. M MOKBUL HOSSAIN sir to say something about today's program.
Assalamu alaikum. Welcome all of you to this session. This is an interesting session. Our keynote speaker will discuss about the carbon dioxide as a contrast. We know we are all of us accustomed with use of carbon dioxide in the laparoscopic procedure, but we can use this carbon dioxide as a contrast, as this contrast is non-nephrotoxic, it is non-allergic, and it is also cheaper in our context. Sometimes when we face the renal patient, creatinine level is raised, we feel discomfort, we need consultation with the nephrologist, and about the complication, contrast-induced nephropathy, we are all concerned about this. But carbon dioxide is a safe agent regarding this issue. And for carbon dioxide, we know this theoretically, but we need carbon dioxide delivery system as well. So we have got carbon dioxide, we have got carbon dioxide cylinder, we need delivery system, and we should be accustomed with this procedure, how to do it. I think Dr. Shekhar will tell about this each and every corner of this aspect, and after this session, there will be a question and answer session. We have done by these few cases with using the carbon dioxide, stenting of the SFA iliac stent using carbon dioxide, and that delivery system is local made here. But we need the dedicated carbon dioxide delivery system. With this few word, and I request Dr. Shekhar to give his speech over the carbon dioxide as a contrast and its delivery system. Thank you all.
Thank you, sir. Thank you very much for your inauguration speech. This program is also live in Facebook pages, so you can share it for your friends and family members. And you can put your questions in Zoom chat boxes and also in comment boxes in Facebook. Now, I would like to request Dr. Raghuram Shekhar to present his keynote speech. Thank you.
Good evening, friends. Good evening again. Can you see my screen?
Yes, we can see you, and we can hear you too.
Okay, great. So greetings from Mumbai. Today evening, we have another very relevant topic to both our countries, because the number of diabetics rising exponentially, and with that, commensurate with that, the arterial disease, atherosclerotic arterial disease is also increasing, and we see a lot of arterial occlusions now. They are on the rise. They are being picked up more. The problem is that many of these patients are elderly with comorbidities, and in addition to that, they have compromised renal function. So in the past, in India at least, I don't know what was the approach overseas. There were two ways in which these cases were tackled. Either they were told that you have a compromised renal function, and so we can't give you contrast, or they were told that, see, you go ahead with a contrast and you face the consequences, because if you don't get an angio and you don't get your your leg fixed, then you're going to lose your leg, or you're going to not get the appropriate treatment, and that might lead to loss of even life, and in some cases. So that was the approach. Many times patients landed up worsening kidney functions following this contrast being given. Luckily now, we have a good solution. When we were all at the beginning of our careers, we used to read a lot about carbon dioxide as an agent. There's a lot of literature, but generally speaking, what was happening was that, the bugbear of carbon dioxide angiography was always the delivery system, and so if you go through the literature, you'll find a lots of, ways in which homemade local contraptions, clumsy kind of equipment was used to try and push carbon dioxide into the blood vessels. And that was really not something which was very exciting or attractive for the patient or for the doctor. And so the whole process of carbon dioxide angiography actually fell into disrepute and disinterest. Now, this all started the whole process of getting carbon dioxide angiography started in India. Restarted, I would say, not started, because there were people who had done it in the past in some of the institutions with the local gadgets. But then, as I said, it fell into kind of a disinterest and disrepute. And then we were all keen to see how we can get it started. And then one of my visits to the United Kingdom, where we were, attending a meeting at the Charing Cross Symposium, I, along with, Mr. Nainesh Mehta, who you may all know, we actually, stumbled upon this kind of gadget, or you can call it a contraption or whatever. And we said, this is something which a country like India really needs, and we should get it to India. And I'm glad to say that within 6 months, we had the stuff in India, and we were the first institution in the country to formally restart carbon dioxide angiography. This was in 2014. And as would happen, it became popular. Other institutions caught up, and now there are quite a few institutions in India who are actually using this contrast media, carbon dioxide, for renal compromise. So today's talk, I'll take you a little bit through the pros and cons of carbon dioxide and how it can be applied to the peripheral interventions as vascular surgeons, and also a little about the anatomy and the physiology of the gadget that is used. It's something which is inexpensive, and it's ideal, tailor-made for countries like ours, where we are extremely cost sensitive, and patients very often forget about carbon dioxide. They are not even able to get access to basic vascular surgeries. So this is something I'll take you through probably over the next 20 minutes or so. Let's start with a conventional DSA that we are also conversant with. The advantage is we get beautiful pictures. We can do our therapeutic procedures with that. And it's a time-tested gold standard. But the disadvantage is that in renal compromised patients, diabetics, especially elderly with other comorbidities, contrast-induced nephropathy, that is what we call CIN, is a reality, and it's grossly underreported because as would have it, very often in our, I don't know what the scenario is in Bangladesh, but in India, very often, doctors tend to play God, and they don't find it actually necessary to consent properly regarding CIN to their patients. And the patient, sometimes unknowingly consents to a contrast being put, and this can be quite harmful for CKD patients. So if a guy has a borderline CKD, you might give a contrast and push him into dialysis. Forget about the iodine hypersensitivity, which is a reality and which we see quite often during conventional DSA. So this is the comparison between a conventional and a non-conventional. So the solution to this is what we are going to discuss today, which is the carbon dioxide angiogram. Let me quickly just take you through a rough schematic diagram. You can see on the left, there is a carbon dioxide cylinder, which so rightly you pointed out has been used for quite a few years now for laparoscopy. It's the same cylinder. What is extra is we need something. We can't obviously connect a carbon dioxide cylinder right directly into the blood vessel, because you need some kind of safety. The abdomen is a big cavity. Blood vessel is a delicate thing. So you can't just pump carbon dioxide gas blindly. So you have this kind of a gauged valve with all the safety features. It's got to connect kind of a connecting tube, which you can see as 3 and 4. And then there is a kind of a disposable plastic syringe, which I'll show you, which has got a lot of safety features, which I'll describe to you. So the gas actually fills in through this tubing in a controlled manner, and you can pull in as much carbon dioxide as you want in the syringe. And then there is a valve, as you can see, number 5 on your picture. That is a valve. It is like a simple, a common IV set valve that you use, a two-way, and you can tweak it this way or that way to allow gas to escape from your syringe through this number 7 tube, which is actually connected to your catheter, which is previously introduced through an angiographic sheath. So this is the basic setup for a kind of a CO2 angiogram that we need to do, and what I will take you through over the next couple of slides. So where are these useful applications for carbon dioxide angiography? Commonly in my practice, most of the CO2 angioplasties that I do for the aorta and iliac disease, we commonly do it for the legs, especially the CFA and SFA, sometimes for the renals, sometimes for the viscerals. Venous cases have been described. I'm not very fond of actually using it except for filter insertion. IVC filters, some of our patients are CKD, and when they need filters, we sometimes use carbon dioxide IVC gram to locate the renals and basically insert the filter. And of course, there's a large group that is routinely doing EVARs for AAAs using carbon dioxide. So these are the basic applications which are currently in use for carbon dioxide angios. A little bit about carbon dioxide properties as a gas. We know it's all endogenous. It's an invisible gas. It's non-toxic, and it's highly soluble. If you say highly, it means it's about 29 times more than that of oxygen. It has a low viscosity. It's buoyant, meaning it floats. It's compressible, non-allergenic, as has been mentioned previously in the introduction. Obviously, it's non-nephrotoxic, which is why we're discussing it today. It's not diluted by blood, like in a contrast, you give a small quantity and it can be diluted by the blood. It's not diluted by the blood, and it rapidly dissolves in the blood and is removed by the lungs in one pass. So that is the property of carbon dioxide gas. Of course, it's not that we can use it for everything. So before we start actually using it, we must know, just as we know where we can use it, we should also strictly know where we should be wary or not be using it. So generally speaking, as a rule, we don't use it for any arterial presentations above the diaphragm. Some people use it for hemodialysis. I'm a little bit wary about using it for hemodialysis, shunts and arteries in the arm, because many of our patients, in addition to being quite weak, they have poor lungs also. And so I won't be using it for, hemodialysis shunts, but there are people and there are papers published where, AV fistulas have been visualized using carbon dioxide, and AV fistula plasties have been done as well. Respiratory insufficiency definitely should avoid, because we know that this gas actually exits through the lungs. And so if the lung function is poor, this gas can actually accumulate in the system and cause deleterious effects. Any type of arterial or ventricular septal defects, any kind of pulmonary AV malformations. The last 2-3 points are, one, of course, of great practical importance. One is restlessness in the patient. So we have to accept that, we need to fine tune and get mentally reconciled to the fact that, with contrast, you get these brilliant pictures. So you might not, if you've been doing years of angiography and you're used to a brilliant picture, then it sometimes is in the initial phase, little bit difficult to reconcile yourself to the fact that these pictures might not appear to be as brilliant as the conventional contrast. And so you need the patient to lie still. So the patient is restless and moving around, then it may not give you as good pictures as you would expect to get from a conventional angiogram. Also, if there's a reduced output, and in children, of course, there is it's not advisable to use this for children. A little bit about comparison between the contrast media or the regular iodinated ones as opposed to the carbon dioxide. You can see that the contrast media is more viscous, more velocity. On an X-ray, and I'll show you pictures, you will find that the on X-ray pictures that you take when you do a DSA, the contrast appears as a positive picture, whereas carbon dioxide appears as a negative. So I'll show you pictures to explain what that means. Of course, the molecular structure is separate for both, but the molecular weight, carbon dioxide is heavier than O2. A little bit more excretion, quite obvious. Contrast comes out through the kidneys, which is why we are discussing all these things today. Carbon dioxide comes out through the lungs. As I've discussed already, there can be some allergic side effects, renal failure. Of course, there's a contraindication. And in carbon dioxide, if you have a poor lung function or an atrial septal defect, a ventricular septal defect, then you might find that it's not appropriate. As far as the pH of blood goes, and if you recollect your physiology of the Hasselbalch-Henderson equation, the pH does shift when you inject carbon dioxide, which might not be the case with contrast. The side effects, a lot has been written about the side effects. I've been doing carbon dioxide angiography for, as I said, from 2014. And, though all these side effects are theoretically, it's there in the books. I have done loads of these procedures using carbon dioxide. And the only thing that strikes your mind when you're doing carbon dioxide is the fact that there is a transient pain. So, the moment carbon dioxide is injected into a vessel, the patient sometimes has a kind of a, he lets out a jerk or says, ouch, and sometimes if they are very sensitive, they might even scream. Just for a transient, there is as the gas passes down the artery, sometimes, especially when you inject it into the tibial vessels, at the time of injection, there is a pain, which is why it's always a good idea to have an anesthetist on the standby who actually sedates the patient or gives the appropriate analgesic or medications at the time of injection, so that you have a still patient. Because as I told you, that if you need good pictures on a carbon dioxide angiogram, you need the patient to be lying still and not moving. So as far as practical points go, probably the only thing you need to be aware about is that there is a transient pain at the time of injection. Now, this is the syringe I was talking about. You can see that this is the, it's about 100 ml capacity. The blue thing here you can see is the lock. So this end at the top gets connected to your connector, which is connected to the syringe, to the cylinder of carbon dioxide. And this blue end is actually connected to your catheter, which is previously already placed inside your blood vessel through your angio sheath. This is the pressure valve. So from the cylinder, on your carbon dioxide cylinder, you need to actually procure this. This is the one-time investment that you really actually need to make when you intend to start carbon dioxide angio. And you can see here, there is an adapter for the bottle. It's got gauges, and it's got an exit kind of a valve onto which your syringe tubing is connected. And there is a pressure. This black thing is the pressure adjusting. So you can turn it more or less clockwise or anti-clockwise to increase the amount of gas that leaks out of your cylinder into your syringe. These are some of the accessories. So just a repetition. So when you start doing an angiography using carbon dioxide, there is a syringe. You need a cylinder. You need the adapter, and this also comes, as I said, with various valves which you can regulate. You don't, unlike laparoscopy, you don't really connect, rapidly connect large volumes in the abdomen. Here you can't do that. You need a very slow regulated, more finely regulated entry of gas into the blood vessels. So you need to actually get this valve system if you need to start doing your angiographies. So this is just to tell you what the whole contraption is about. So there is a 100 ml syringe, and once you connect this to the gas and this to the patient, and you open this valve, it's like a IV set. You know, when you're giving an IV set with a two-way, you can tweak the valve in one direction or the other and fill up this syringe. So the moment gas enters this syringe, you know, the piston starts coming back, and this number 2, which you see there, which I'll show you more in detail, that actually locks at one point so that, you know, the system doesn't back off totally. So you can lock it if, depending on how much gas you need to load, you can lock that at 20, 40, 60, 80, or 100. So this is in brief about the contraption itself. As you can see, there is a syringe. One end goes to the patient catheter, the other end goes into the cylinder. And you know, this is a great, it's a very simple, inexpensive syringe, but it's so beautifully designed that it's got safety features that, you know, above a certain pressure, you know, this lock just gives way and allows the CO2 to escape. So there is no way accidentally you can inject high pressure of carbon dioxide into the patient. There are so many safety features in this syringe that prevent that disaster from happening. This is the lock, which, as I told you, I'll show you the, right. So this blue thing that you see here at the end of the syringe, that is actually a lock which you can fix manually to decide how much of gas you need to take in. And you know, this has got a kind of a safety feature that beyond a certain pressure in the syringe, the valve just opens up and allows the gas to escape out of the syringe rather than into the patient. So that is something which is extremely safe feature of this simple looking syringe. How much gas can you inject? So this chart actually tells you the dosage of carbon dioxide. So depending on what part of the body you are imaging, you can, you know, you start with 20 ml pressure chamber volume to 100, maybe for the entire aorta, you might need to inject 60 to 100 ml of the gas, which the syringe will show you. So depending on what part you want to see, you can inject at one go 60 to 100 ml. And as long as your lung function is good, you know, there is no real risk, because this really gets absorbed rapidly and gets thrown out through the kidney, through the lungs in one shot. So if you stagger your shoots while you study your films, you can safely put in quite a lot of carbon dioxide into the patient's system. There are certain technical things that you need to know when you do a carbon dioxide angio. If you need to study the legs, the arteries of the legs, you need to raise the legs by about 15%, 15 degrees, slightly up, so that you know, you get a better travel of the gas into the leg. If you're planning to look at the renals, then you need to tilt the patient, raise the ipsilateral side by about 30 degrees. And sometimes, you know, the aorta and iliacs may be, you know, maybe difficult to visualize on the first shoot because of, you know, constant bowel movements, the gas movements inside the bowel, which obliterates your visual field. In which case, sometimes you may need to give maybe an injection of 20 milligrams of Buscopan to immobilize the bowel while you actually take your shoots. There are certain other tips for improving imaging in carbon dioxide, and I'll tell you at the end of this where you can get all this data to go through it. This is just an introduction. As I said, you can raise the leg for up to 30 degrees. It's better to sedate the patient a little bit, because as I said, you know, when you are doing CO2 angiography for the first time, you know, what strikes you is that my DSAs used to be give me such beautiful, brilliant pictures. This doesn't look as brilliant. So that is some kind of a mindset that you need to slowly get used to, because we are treating patients who really can't get the contrast. And so sometimes you need to cut a little bit of corners while you're doing carbon dioxide in terms of the brilliant pictures that you get. So to get a better quality image, you need to keep the patient from moving. So a good sedation. Uh, it's always better, like when we do a DSA, we take one shoot maybe in the iliac, and sometimes with that shoot, we can just chase the bolus down through the femoral artery right into the popliteal. For a carbon dioxide, you need to do a selective injection. So you need to actually inject with an end hole catheter close to the area of interest. So rather than wait for it to travel all the way down the thing. So you need to be more selective in your injection. You need to focus on your area of interest and shoot from close by. Uh, Sometimes it's beneficial to give a little bit of NTG into the arteries prior to injecting CO2, because the CO2 itself is buoyant, and as it goes down the artery, it can cause a lot of spasm and pain for the patient. So in addition to an analgesic and maybe a sedation, some amount of NTG is also given at times. You need to tell your technician to set the frame rate. So normally when we do our DSAs, we do 3 frames or 4 frames per second. For a CO2 angiography, you need to up it to 6 frames a second. And then your technician should be comfortable with, the how to reform the images. So the software in your machine sometimes can help you to, actually realign and superimpose multiple frames to give you one composite image. So a little bit of technical knowledge of the machine is something which you need to learn. For us, I don't know how it is in Bangladesh. For us, we have, our technicians are pretty smart, sometimes too smart, but generally they are quite smart, and they get in a couple of sessions, they quite master this whole technique of showing us the images on carbon dioxide angiography. So this is what a carbon dioxide angiography looks like. You can see, if you want to know, if you look at the picture right at the top, you can see, just as I told you, you need to have a targeted shoot. So when I want to see the common femoral, profunda, and the SFA, I need to keep the catheter at probably the upper end of the CFA and then shoot. And as you can see there, a DSA would look black. Positive film, this looks like a road map. So it's actually a carbon dioxide. So when you shoot carbon dioxide, it looks white rather than black. But other than that, I'm sure all of you will agree that this is as good an image as you would get with a DSA, right? So this is a carbon dioxide study showing the common femoral and the profunda femoris and the upper 2/3 of the superficial femoral artery. This is a picture just I put to show you what is the difference, and once you learn the trick of how to do it, how to keep your patient still, how to sedate, how to give a little bit of NTG, how to increase the frame rate, then you can get quite good pictures even on CO2. And you can see here the same patient, same picture. If you put contrast on one side, on the right, and you see CO2, it's pretty much the same. So, for all those who would probably bias your mind saying that, oh, we have seen it all, it's useless. Well, if you're keen and you stick to it and you learn the trick, over a period of time, you will master it, and you can get as good pictures with the carbon dioxide as you would get with conventional contrast. This is something I'm just sharing. I edit a book called the Yearbook of Vascular Endovascular Surgery, which is the 2020 is actually become 2021 due to the COVID pandemic. We have, this was the first edition in 2016, and then 18 and 21, it's in print right now. So in the 2016 yearbook, there is a chapter written by me along with my postgraduate registrars on carbon dioxide angiography and the vascular surgeon. So those of you who would actually want to at leisure, recapitulate what we've discussed today and actually get to the finer points of how to get started with a carbon dioxide angiography would probably would be served best if you get a hand on this copy of the book and go through this chapter. It has all the details of how to, and get started, and what technical adjustments you need to make, and what is the literature on it, and what you should do and what you shouldn't do while doing a carbon dioxide angiography. These are some of the pictures I've shared from the book. You can see on the left, this is a mid-aortic syndrome, which we did a stenting. You can see this is an elderly lady with CKD. She's 76-year-old, and she had a tight mid-infrarenal aortic stenosis, which is marked with an arrow, and you can see it beautifully even with a CO2 angiogram. Similarly, you can see almost all vessels. It's always advisable to start with the larger vessels, and as you get comfortable, the most difficult and the most technically demanding is the tibial vessels. And so probably start off by doing the aorta and the iliac and the SFAs. And then as you get better and better, you can actually switch to doing CO2 angiography for the tibials as well, which we do routinely now. This is just to show you that you can very comfortably do an angioplasty. This is a 74-year-old male diabetic with CKD, but not on dialysis. Crippling claudication is a well-known film personality in the local Marathi film industry. And you can see on the left, there is a long, SFA kind of a lesion, which, we have done what is called a subintimal angioplasty, balloon angioplasty using a subintimal technique using pure carbon dioxide. And we've been able to actually restore the uh, blood flow through the SFA. So this is just an example of how CO2 works. That is in brief about CO2. There is a learning curve involved in this. I'm not denying that. But, with all new procedures, there will be a learning curve. It's just a kind of a mental block, when you have the luxury of doing a DSA, then probably doing CO2 to start with is a little bit more technically challenging in terms of getting, ideal picture perfect images. But I can assure you that, the benefits are so great that, and with yeah, patient awareness is quite a lot now. CIN is something which a lot of patients read up on the internet. They are very aware of contrast causing deleterious effects on the kidney. They are scared of the dialysis word. And so obviously, if you tell them that I'm going to give you contrast and you might get into dialysis, it's very likely that a significant percentage of your patients are going to say, no, we don't want the procedure. I don't want to get into dialysis. I'm doing fine. So this is something which is very, very useful in the armamentarium of vascular surgeons who are doing interventions in their day-to-day practice. As I told you, number of CKD patients is on the rise along with the number of diabetics, and a large number of patients in whom we are today doing limb salvage work using carbon dioxide are actually diabetics. So this is in short about CO2 angiography. I'd be happy to share your thoughts and experiences on what the scope of CO2 is in your country.
Just before going to question and answer session, some of our colleagues participated somewhat little later.
Yeah.
We can share a small video on this delivery system. Can I show you the video? This. So this is about carbon dioxide and delivery system. Now the question and answer session. Please raise a question from the audience side.
I have got a query in selecting patient
Yeah.
of carbon dioxide. Which one is it the creatinine level or EGFR? Sometimes we have seen that serum creatinine level 2 is optimum for up to 2. As in some center 1.6 or 1.7, they don't like to do the conventional angiogram to avoid the CIN. So what is your level of creatinine which we go to carbon dioxide and or any other limit?
Well, I think you're right. It's not exactly the creatinine. Generally, they need a nephrologist clearance, and usually from CKD, when the EGFR, what you call ESRD grade 2, from stage 2 onwards, they usually say avoid doing, avoid giving contrast. So generally speaking, it's not only the EGFR, but also, the other parameters. It's very difficult to predict the journey of a CKD patient when he will go from 2 to 3 to 4 to 5. Very often we have seen with just one single contrast, the patient rapidly, the kidney functions deteriorate. So by and large, if the patient is labeled as, where the EGFR has started to deteriorate and he is in that what you call a ESRD grade 2 onwards, the nephrologists usually tell us to avoid giving contrast.
Dr. Shekhar, I'm Dr. Bhuya.
Yeah.
Why you advise to use carbon dioxide below diaphragm? Why not in coronaries? Why not in carotid?
Okay, a couple of reasons for that. For the coronaries, as I said, you need a still patient. So your pictures are not clear. If the heart is continuously beating, the things get blurred. You can't see a thing. So that is one basic reason. Secondly, it's not been studied in the coronaries even. I don't think there have been any studies or trials in the coronary, because the basic premise of doing a carbon dioxide, the whole thing is that you need a still patient not moving and the heart constantly pumps. So that is one. Secondly, I think there are safety issues because of which it is not done for the carotids.
Do you think it is cardiotoxic or nephrotoxic or neurotoxic?
No, it isn't. It isn't. It's not neurotoxic, but injecting carbon dioxide into the brain, what effects it will have on, have not really been studied. So it's not been considered safe for neuro interventions. And cardiac, of course, with a constantly pumping heart, it's not the ideal contrast agent for visualizing the coronaries. You need a still patient.
In our setup, cath labs are mainly for cardiac patients and for coronaries, and we are doing peripheral vascular angiography and stenting in the cardiac cath lab. We have got not so separate cath lab for vascular surgeons, yet to be in near future. So that is important. If cardiologists cannot be comfortable with this angiography or this agent, it is very difficult for vascular surgeons to use routinely.
Yeah, I mean, you see, the basic thing is that, the cardiologists have to understand that, the coronaries is one game and the peripheral is another game, So you can't use the rules for the coronary for the peripheral vessels. So when it comes to coronaries and it's a life-saving thing, then probably, the kidney functions come secondary, right?
Yeah.
Whereas when it's limb salvage, then, patient safety again, you have a choice there where you can try and save the kidney functions from deteriorating further. When it's a coronary issue, sometimes it's there is no choice. It's a life-saving situation. Whereas most of our procedures as vascular surgeons are for limb salvage. So there we have a chance, we have a choice, and we can exercise an option.
Okay. Thank you for your comments.
Hybrid procedure like some contrast, some CI, carbon dioxide. Dr. Mokbul can remember, he is the pioneer of this technique in Bangladesh, and he took lot of trouble and lot of pain in arranging this in Ibn Sina. And sometimes we have completed this stenting, and we have given some amount of dye. And is it safe?
Yeah, you see, basically, there are two things I'll comment on your observation. One is, all of us, when we started doing carbon dioxide and we were not really that good at it, we were minimizing the contrast, because ultimately CIN is directly related to the amount of contrast you give, right? So we reserved the little bit of contrast for the tibial vessels, because we used to find that as difficult to visualize, because in the small vessels, when we used to inject carbon dioxide, patients used to have pain and move their legs. So we couldn't visualize. So we used to, keep the little bit of contrast reserved for the tibial vessels. But by and large, for the aorta, iliacs, the CFA and SFA, up to the popliteals and maybe the tibioperoneal trunks, I can tell you that we don't use contrast. But yes, it is always it's wise to keep little bit of contrast on standby, because even if you do what you call a hybrid, if you minimize the amount of contrast that you're giving, you're also minimizing the chances of CIN, because CIN is dose dependent, right? So if you can minimize the CIN, minimize the amount of contrast that you give, what you call a hybrid approach is worthwhile.
Thank you.
I may I make a comment?
Yes, sir.
Yes, sir.
Yeah, I completely agree with Dr. Shekhar. It's a learning process. Whether you get comfortable with the procedures as well as the techniques. Once you get the techniques, I don't see any reason. Once you get comfortable and used to it, I don't see any reason why you couldn't apply these techniques of diagnostic and interventions all across the board, irrespective of renal functions. You can apply it in normal functioning, normal kidney functioning patients. In fact, this is less expensive than your contrast media. That economic terms is better for the nation. There are certain advantages. In fact, even if you get used to this tibial base, if you get used to these procedures, there's certain advantage to this, because the CO2 is going to go through the small collaterals, and if it's a slow flow, it's going to show up the distal vessels runoff better than your conventional angiograms or conventional DSA. So there are advantages to these techniques. It's just a matter of getting used to it, various way how to improvise or maximize the utility of these techniques.
Correct. I agree. Absolutely. There is a kind of a, mental block, and you need a little bit of patience, very often I have seen a couple of my colleagues, they've done 2 or 3 procedures and they said, oh, we can't see a thing, and they've just abandoned it, there is a learning curve. You need to be patient and keep fine tuning your skills. It takes a while before you actually master it, but you need to get started. Unless you get started, really, you can't, go through the learning curve.
So mind setup is very much important before starting this.
Yeah.
Initially, maybe the picture quality, when we started, some picture quality we are not satisfied. But after a few shots, the picture quality we feel it is better and it is understandable.
Yeah.
One thing, we can use this carbon dioxide gas using 2 French or 3 French catheter. So during only diagnostic procedure, we can complete the procedure using a small caliber catheter.
Yeah.
Is it?
Yeah. Yes. Yes.
The
trick is not only in the caliber, but your shoot should be close to your target area of interest. Not far away. Like contrast, you can shoot in the aorta and still chase it down to the popliteal. Here, if you need to see the popliteal properly, it's better to keep your catheter in the distal SFA. That's when you get a good picture. So these are small, practical things which you learn on the way while you do it.
So selective catheterization is utmost important here.
Yes, yes, yes.
And
The
another thing,
other part is even if it doesn't show in the first injections, you can keep repeating it because
Yes.
there's no toxicity to it. There's no volume limitations.
Absolutely.
Is a contrast. You have even normal patients. You try to limit the volume. Normal renal functions. You try to limit the volume of the whole diagnostic or intervention procedures. You can, as far as I know, there's no volume limit. Only limit is intervention between the injections. And you can say, okay, yeah, we wait instead of injection between the injection, wait for a minute or less. You can increase the interval of injections 1 to 2 minutes. Then gas should be all absorbed by the time, whatever you injected.
Yeah.
So there's no limit for gas injection for the total procedures.
Yeah.
so what is the ideal interval time? Is it 3 to 5 minutes? Is it 1 minute or 2 minutes between two shots?
No, normally I take about 1.5 minutes between two shots, Wait for it, shoot, take a picture, analyze the picture. While you're analyzing and discussing with your assistant what you have seen, the gas has gone out through the lungs. So then you can take your next shoot. So instead of rushing through the, frames, we take a little bit of more time so that, the whole process of the gas getting out of the system happens.
Another thing, without DSA, can we see the picture without DSA?
No.
I've not tried it, but I don't think so.
No, you're not, because it's a negative.
Yeah.
The CO2 is negative ions.
So
You have to have a DSA.
when there is DSA, chance of radiation is more in case of carbon dioxide angiogram.
Yeah, because you increase the frame rate.
You're increasing the frame rate, correct. So radiation is more, yeah.
The other part, I have to just remember, if you have a capnograms during the procedure, even people with the COPD, it's not an issue. You can, again, increase the interval of time. In that situations, you may have to be conscious about the amount of CO2 inject.
Yeah.
There's no absolute contraindication. As literature say, you shouldn't inject in coronary because technical problem. Just like MRA is not feasible for coronary because it's a beating heart. The other issue is the animal studies show there's some cardiac ischemia, coronary ischemia because of the gas bubble, but that's not, that's been done in human studies. And the animal studies show there's some neurotoxicity of brain barrier, blood-brain barrier disruptions cause convulsions. But again, it's not been proven to be in human studies. But as long as you're not doing the cerebral and thoracic aortic, you're great.
Yeah.
It has been here in the United States, has been mindset. People hasn't been adapting to it because you get used to it and you don't think out of the box. It's just driven in a tunnel, and is being used more and more centers because the systems what you have, we have even less complicated system. You just get a bag, filter CO2 in a plastic bag, and then you put on your table and use it, say plastic bag, 200 cc of CO2 as a low pressure, less than 10 psi in the bag. So it's not causing any disruptions the lining of the arteries.
Doctor, I have got a theoretical. I have seen in the the only with the help of duplex, the ultrasonogram, can we put a stent in CKD patients if the lesion is localized in the SFA, very short length? Do you have got any experience?
People are doing it. People are putting in bedside IVC filters with purely on ultrasound. So if you're that good at ultrasound, then why not? People are doing ultrasound guided procedures. They're doing ultrasound guided fistuloplasties, for instance, for the AV fistulas, purely ultrasound guided in the outpatient. So I don't see any reason why it can't be done. You need to be really good, that good at ultrasound. In our country, probably the radiologists are probably better equipped to do that. The vascular surgeons might not be as good as trained in ultrasound as probably the radiologists. But yes, there are centers which are doing a lot of interventions purely ultrasound guided. So I don't see any reason why. I mean, in a CKD patient where you don't have CO2, ultrasound is one option.
So below diaphragm, no question. Every procedure could be done with carbon dioxide.
Yes.
Yeah.
But above diaphragm, there is if there is a subclavian artery stenosis and deployment of subclavian stent, and the vertebral artery arises from the subclavian artery, could it be done with carbon dioxide?
No, I mean, the whole issue is to not allow the gas to go into the brain, right? So above the diaphragm, that is an issue. Some amount into the carotids.
Actually, carbon dioxide should not be injected above diaphragm. It is one of the most important barrier line for vascular surgeons.
Yes.
For doing lower limb carbon dioxide angiography, position is the leg and elevation. But during upper limb procedure like fistuloplasty or anything, what is the position here?
Neutral. Neutral. Supine position. Doesn't need any special.
But we need elevation of the hand.
Due to volatile, the carbon dioxide is a highly volatile and diffusible gas. That is why limb elevation can cause move upwards.
Yeah, it's got what we call buoyancy. Yeah, so it floats, and that's the reason why you actually lift the leg up. You know?
Well, you have to think about this also can be used as a reflux procedures. There has been many reports here. The people who could not cannulate the iliacs or aorta and to see the status, he just injected the femoral and lift up the head and wait for the pictures to show up the CO2. It does show but that's when you get well comfortable with the procedures. That's way we are thinking way ahead of time.
So is there any chance of mixing of air with carbon dioxide during injection?
Well,
that's why you have to parse the tubing.
Yeah, you need to flush it. So once you, there is a kind of a drill that you need to do before you start actually injecting. Once you connect it to the cylinder, you have to purge the system of air. So what we do is connect it to the cylinder, and then 4 to 5 times we open and close the valve to purge the system of all the air. And then we connect it to the patient.
Any more question? Already we have crossed 11.
We're enjoying the session.
Jia,
Sir. Thank you, sir. I think it was a very good and interactive session, and we have learned this new technology that carbon dioxide as contrast medium for peripheral vascular interventions. Now I would like to request Dr. Raghuram Shankar, sir, to say something about today's program, please.
Yeah, at the onset, thank you for having me again here. It's always been a pleasure talking to you people and sharing your experiences. You know, all the issues that are there, which you people face, is exactly the same. So our mind also works in the same way. So most of the things that we discuss are so relevant to us as well as you. So it's always a great kind of an experience for us in India to sit and share knowledge like this. And I hope that this kind of tradition continues on a more and more larger platform, and that we can actually interact more. God willing, once this COVID thing is over, probably we can also visit each other's centers and share our experiences.
Yes, sir. Thank you, sir. Yes, as you said, it's a new technology for Bangladesh. As we have experienced some example, as Dr. Enamul sir said, that Dr. J. Mogul sir practiced some carbon dioxide related procedures here, but we have a learning curve, and we need to learn more about this. And now I would like to request Dr. M. Abdur Rahman sir, our beloved mentor, to say something about today's program. Dr.
Well, again, thank you for having me. Thank you, Dr. Shekhar, for beautiful presentation and trying to stimulate these Bangladesh physicians to utilize this technique. I do believe this is a very valuable and essential technique for Bangladesh. In fact, for all over the world, because we know the diabetic incidence and the diabetic vasculopathy is increasing. And since the longevity of the people in Bangladesh is increasing, so you're going to see more and more vascular disease and CKD disease. So this technique needs to be needs to acquire and get well acquainted for your patient population services. The advantages has been already discussed. So you guys, you people need to pay a little more attention to adopt these techniques.
Thank you, sir. Dear audience, as you know that scientific partner of today's session was Optimate Germany and Plasma Biotech. I would like to thank them for their contribution in this webinar. Now it's time for vote of thanks and closure of the today's session. I would like to request Dr. J. M. Mogul Hossain sir to express his feelings about today's program. Thank you.
Well, from this session, we learned each and every corner of carbon dioxide. Definitely, this is cheaper. This is non-nephrotoxic, this is non-allergic, and this is beneficial for us. We are eagerly waiting for this procedure in each centers where the peripheral vascular interventions are done. We have got carbon dioxide, we have got cylinders. The laparoscopic surgeons are randomly using this gas, and we need dedicated the delivery system. If we can get the delivery system, we think we will be accustomed, all of us, using this carbon dioxide as diagnostic as well as the intervention procedures, particularly peripheral intervention in different centers. With these few words, I congratulate each and everyone from home and abroad, and thank you again. Assalamu alaikum.
Thank you, sir. Thank you very much. Assalamu alaikum.
Assalamu alaikum to all.
Sir, Abid sir.